whether they are acute or insidious, predisposing factors like trauma or contact lens wear, drug history, what we mean previous treatment, also the history of recurrence, it's very important, and medical history, whether the patient is receiving treatment for any systemic disorder like hormonal imbalance, rheumatoid arthritis, allergic disorders. History taking, from my own experience, is the most important part of your encounter with the patient. About history and symptoms, usually in bacterial keratitis, there is a history of an epithelial breakdown. The organism cannot access the cornea except if the epithelial barrier is broken. Like, for example, a foreign body, contact lens, dust or sand, fingernail surgery, anything like that which compromises the epithelial barrier. In fungal keratitis, history includes ocular injury by a plant or by any thing in the farms, like farmers and gardeners. Also, there is history of no response to antibiotic eye drops, and also a history of prolonged use of topical steroids. For example, in cases of keratoplasty, we give the patient for a long period, we give him or her topical steroids. Symptoms in bacterial keratitis include severe pain, which is usually referred to the forehead and intensifying during night sleep. Also, there is significant diminution of vision and severe photophobia, lacrimation, and blepharospasm. On the contrary, fungal keratitis usually presents with moderate to severe pain, usually moderate, and no significant photophobia or lacrimation. So when the patient comes to you with an open eye with no visible or prominent photophobia, you can expect a fungal origin. About the signs, on the left side of this slide, you will see the signs, the shape of the ulcer, the epithelial cover, the surrounding area of the lesion, the conjunctival injection, the hypopyon, the perforation, and accompanying signs. They are different from bacterial to fungal. The shape of bacteria, usually it is a suppurative lesion, and it is a suppurative lesion with a serrated or spiky edges. This is a very important sign. Surround the epithelium of in the bacterial lesion, usually the defect is equal or larger in size than the area of stromal suppuration. On the contrary, fungal keratitis is characterized by a defect in the epithelium, smaller in area than the underlying area of stromal suppuration, and the epithelium even may be intact with the suppuration under the epithelium, which is intact. The surrounding area shows edema and cellular infiltration in bacterial. In the fungal keratitis, you can find satellite lesions or a deeper layer of suppuration that seems to be continuous with the hypopyon. You can see that the back side of the lesion is continuous with the hypopyon itself. The conjunctival injection is severe in bacterial, moderate in fungal. The hypopyon is present in both cases, but with a horizontal upper edge in the bacterial, with a thick, regular upper edge. Perforation is likely in both situations, and severe lid edema, conjunctival chemosis is present in bacterial keratitis. For tips for treatment, in bacterial, the preferred agent is fortified ceftazidime or fortified vancomycin or linezolid. In fungal, we can give voriconazole or amphotericin B or natamycin, and you can even give two kinds of antifungal in fungal keratitis. Regarding the frequency of treatment, it is every hour for the first 2 days in bacterial keratitis. Then we assess the decrease in dose very slowly. Every hour for the first 2 days in fungal, then we assess. We decrease the dose very slowly. When to stop treatment? We stop treatment in bacterial keratitis when the epithelialization is complete, and in fungal keratitis, we stop it at least 1 month after the resolution of suppuration. This is a case of bacterial keratitis with horizontal upper edge of the hypopyon and starting vascularization. This is a case of fungal keratitis where you cannot see even where is the lesion. The lesion is continuous with the hypopyon in the anterior chamber. This is a typical fungal keratitis with spiky feathery edges, and the hypopyon is not regular, the upper edge is not regular. Here is a satellite lesion in far away from the main lesion, but this after resolution of infection. Do I have time or I exceeded my time? I think 1 minute.
Yes, 1 minute.
Causes of refractory microbial keratitis. Usually the patient who is not responding to treatment, one of these conditions may be present: wrong diagnosis or mixed infection. The case is bacterial and fungal, bacterial and viral, or fungal and viral. Patient compliance is very important. Patients may not be taking the drugs properly. Ineffective antimicrobial eye drops. The eye drops are ruined or are not effective, and drug toxicity. Corticosteroid use in infectious keratitis is a very important tip. There is no conclusive evidence that corticosteroids improve the clinical outcome of fungal or bacterial. But the potential advantage of corticosteroids is a suppression of inflammation, and this may cause better environment for the antimicrobial activity and better healing and less corneal scarring and visual loss. The potential disadvantages include reactivation of infection and inhibition of collagen synthesis predisposing to corneal melting. So the rules: use only corticosteroids in severe lesions compromising the visual axis after significant control of the disease by antimicrobial agents for 2 to 3 days, or combined with adequate antimicrobial cover, and use on cessation of clinical improvement after initial favorable response to antimicrobial agents. So you can use corticosteroids, but with these rules. Thank you.
شكرا دكتور علاء.